My name is Zolty. I'm a cardiologist. I'm doing advanced heart failure and heart transplantation. And in my training, I had to do a lot of catheterization in patients with pulmonary arterial hypertension. I train at the University of Colorado in Denver, which is considered as one of the best centers in pulmonary arterial hypertension. Working with this patient in the cath lab, I fell in love for PAH, now leading a pulmonary hypertension program here in Omaha, Nebraska. Today, I would like to speak about some innovation in the field of pulmonary hypertension. As you may know, pulmonary arterial hypertension is a progressive lethal disease. Patients unfortunately die from pulmonary hypertension if not treated. We should go just back a little bit to the pathogenesis at the mechanism of what we believe cause pulmonary arterial hypertension. And we know that when patients suffer from pulmonary arterial hypertension, they do have what we call endothelial disruption. Endothelial is the inner layer covering the vessel of any vessel, especially the pulmonary arterial tree. And if you have any damage of this endothelial layer, you are going to make some small thrombi, some small clots. And one of the initial treatment of pulmonary hypertension was in the 80s to treat this patient with anticoagulation. Unfortunately, there was never any prospective study looking at the benefit of anticoagulation, only a retrospective study, and most of them show that there is some benefit of anticoagulation, blood thinner. However, because there was never any prospective study, it's just a 2B indication. Not everyone needs to be on anticoagulation because, again, hasn't been shown really to improve survival in patients with PAH. The second main phenomena that patients have with pulmonary hypertension is vasoconstriction. Vasoconstriction meaning that the vessel tightens when you do have the disease. And that's the reason the three classic pathway how we treat today pulmonary arterial hypertension. We know that patients with PAH have too much endothelin, which is one of the most potent vasoconstrictor we have in our body. So we block this endothelin, causing less vasoconstriction and a vasodilator effect. We also know that patients with PAH don't have enough prostacyclin. So we do substitute this lack of prostacyclin with some prostacyclin. We do have IV, inhale, oral prostacyclin to give to patients. And the third pathway, which is also a vasodilator pathway, is the lack of nitric oxide. Patients with pulmonary hypertension have a lack of nitric oxide, and therefore we give them a PD5 inhibitor like sildenafil or tadalafil, or a SGC stimulator like riociguat to increase the nitric oxide pathway, increasing cyclic GMP. Cyclic GMP really vasodilate. But all these therapy, this classic therapy, do not stop the progression of the disease. They slow down the progression of the disease without stopping the disease. We also, and that's the last point and the newest point I want to make, is when patients do have pulmonary arterial hypertension, the wall of the vessel get thicker. If the wall get thicker, the lumen where the blood travels gets smaller and smaller. And that's the reason why patients get less blood, less oxygen, less hemoglobin, less oxygen, more shortness of breath. And this thickening of the wall get what we call increase in the resistance, leading to right side heart failure. About 15 years ago, there was a paradigm shift in the understanding of pulmonary arterial hypertension, thinking, why do these patients have a thickening of their wall? is because there is proliferation of endothelial cell, smooth muscle cell, like neoplasia, like a tumor. Maybe if we block this progression, this proliferation, we may stop the disease and maybe even regress the disease in making the wall thickness less thick and smaller. Therefore, about 15 years ago, there was a very interesting clinical trial with a drug called imatinib or Gleevec. Gleevec has, for patients with chronic myelocytic leukemia, has been a revolution. Patients with CML in the past needed to have a bone marrow transplant. With the administration today of Gleevec, has been a revolution, and patients can live with CML, with this chronic myelocytic leukemia, for years and years with absolutely no progression of their disease. Similarly to CML, the idea was maybe if we gave an agent like Gleevec or imatinib to this patient, we may stop the proliferation of endothelial cell and smooth muscle cell in the wall of the vessel and stop or even regress the disease. This trial was called IMPRESS, was done about 13 years ago, and the results of the study was absolutely beneficial. However, more than 30% of patients quit the study because of side effects. And also patients on anticoagulation, on blood thinner, developed some intracranial hemorrhage. And the FDA, because of the side effect, decide not to approve this drug for pulmonary hypertension. So just to give you a background that there is really a paradigm shift in the understanding of the disease. So the new drug that has recently been approved by the FDA is being called sotatercept. So that's another mechanism. We know that in our system, every cell has like a yin and a yang. There is activin, which a system which stimulates the gene, while the bone morphogenetic protein system is slow down the activin and slow down the proliferation of cells. So in our system, in a normal system, you do have a balance between BMP and activin. We also know in patients with pulmonary hypertension, they do have too much activin. So these new medicines, sotatercept, block the activin. Activin is like an accelerator. It does promote proliferation of cells on the gene. So if you block the activin, you re-equilibrate the BMP and the activin, reducing this proliferation of cells. And sotatercept was shown really to improve patient pressure as well as improving their 6-minute walk distance as well as their quality of life. So sotatercept was being approved by the FDA for the last year and really has changed the field of PAH. Another group similar to the Gleevec, but as I said, Gleevec was not approved by the FDA because of the side effects. So the idea was maybe if we could give a Gleevec as an inhaler without systemic effect, patient would absorb the drug into the lungs without having any side effect. There was a clinical trial with inhaled imatinib, inhaled Gleevec if you want. Unfortunately, the study was not positive because most likely imatinib was not absorbed by the lung. However, another company was able to produce a super imatinib, which is being absorbed by the lungs, called GB002 or seralutinib, showing a significant improvement in the pressure as well as the PVR. Currently, there is a phase 3 with this drug as an inhaler. So in summary, I just want to say the drug we have currently until now were vasodilators. They do slow down the progression of the disease, but don't stop the disease. Now we do have one drug approved by the FDA. Hopefully a second one will be approved. These two drugs stop the proliferation that occur in pulmonary hypertension and hopefully will stop the disease and potentially even regress the disease. So we are getting closer to maybe a cure of the disease with agents like sotatercept and seralutinib. Thank you for listening. My name is Zolty, and I'm aware that my patients are rare.